Okay, so good afternoon, everybody. Thank you for joining our today's webinar with focus on neurorehabilitation. We will have today two webinars. The first one will be entitled Gait Rehabilitation in People with Hereditary Spastic Paraplegia, and will be presented by Jorik Nonnekes from the Radboud University Medical Center in Nijmegen in the Netherlands. And the second one is entitled Respiratory Physiotherapy in Parkinson's plus syndromes, and will be presented by Martin Sup from the Charles University and General University Hospital in Prague in Czech Republic. My name is Sanja Hermans, and I work at the Institute of Medical Genetics at the University Hospital Tübingen in Germany, and I'm responsible for the training activities of the European Reference Network for Rare Neurological Diseases. And together with another network, with the Reference Network for Neuromuscular Diseases and the European Academy of Neurology, we have launched this initiative, this joint webinar series. So I would like to give you a short information. Just let me go to my next slide. Short information on those reference networks. So in Europe, there are 24 reference networks, each covering a different area of rare diseases. They have been established in 2017 with the aim to facilitate and intensify collaboration and exchange of knowledge and expertise between expert centers. So our grouping of expert centers around Europe has 32 full members institutions in the countries with dark blue here on the map, and we have also 10 affiliated partners in the countries in light blue. And our network is covering 6 disease groups, which you can see listed here. Okay, a short information about the webinars, or on today's webinar. We will have 2 webinars, each of 25 minutes and 10 minutes of questions and answers at the end of each topic. So please write your questions in the Q&A box in the lower toolbar. We are recording this webinar, so it will be put on our website in the next 2 weeks at the latest. And after the webinar ends, your browser will open automatically a post-webinar survey. So please just take 2 to 3 minutes to fill it out. There are 11 questions. The first 11 are on the first part, gait rehabilitation in people with HSP. And the second part, from 11 to 20, are the questions about the second part of the webinar, respiratory physiotherapy in Parkinson's plus syndromes. Okay, so about next webinars. So we are, this is our last webinar before the summer break, and from September we are continuing with our initiative. You can see here all the webinars, all the upcoming webinars, but of course you can always visit our website for an updated status of the webinars. So I would like to present you Jorik Nonnekes, who has obtained his medical degree from the Radboud University in Nijmegen in 2010. And he also performed a scientific elective at the Institute of Neurology at Queen's Square in London. In 2015, he obtained his PhD degree entitled Balance and Gait in Neurodegenerative Diseases. What startles tells you about motor control. His current position is consultant physiatrist and researcher at the Radboud University Medical Center. And he focuses on diagnosis and personalized treatment of complex neurological disorders, and in particular on gait impairments in 3 groups of neurological disorders, that is Parkinson's disease, rare and hereditary movement disorders, and stroke. So, Jorik, thank you very much for accepting our invitation. And the floor is yours. I will stop sharing my screen.
Yes, well, thank you very much for the kind introduction. I will now try to share my screen. Yes. So I also would like to thank the European Reference Network for Rare Neurological Diseases for the invitation to give a webinar on gait rehabilitation in people with hereditary spastic paraplegia. I'm also curious about the backgrounds of the participants. So perhaps, Sanja, you can introduce a question so people can vote. Thank you.
Here's the question.
And in the meantime, I will go to the next slide and introduce you to the learning objectives of today. So in my talk, I will focus on pure HSP, which is characterized by progressive spasticity and muscle weakness in the legs. And today I will introduce the typical gait pattern in people with HSP. And I will introduce that management involves complementary non-pharmacological, pharmacological, and surgical interventions.
Okay, I will just show the results from the poll.
Okay, thank you. So the majority of participants is physiotherapists, but also neurologists, physiatrists, residents, nurses, and also for patients or patient representatives. So thank you, Sanja.
Okay.
So let me see whether. So why do gait impairments in people with HSP emerge? It's a combination of spasticity, which is most pronounced in the calf muscles and the hip adductors, sometimes also in the hamstrings. People tend to have a relatively mild muscle weakness. There's reduced selectivity. We also often see that people with HSP have difficulties to make rapid leg movements. There is often a degree of impaired proprioception, and over time contractures can emerge. This can be contractures of the hip, knees, and ankles. So here you see a typical gait pattern in a person with HSP from the frontal plane. So there's toe walking, and often you see a degree of narrowing of the gait width. And in this patient, there is even gait scissoring due to overactivity of the hip adductors. This is another video in slow motion from another patient from the sagittal plane. And you can see that this patient has difficulties to make a heel strike. Instead, there's a midfoot strike. There's an early heel rise. And during the swing phase, there is a tendency to foot drag, which is most pronounced on the right side. This is another example of toe walking in HSP. This lady has HSP and contractures of the calf muscles, and that results in toe walking. Well, gait rehabilitation aims to improve gait capacity in people with HSP, and this is a fascinating field. And in daily clinical practice, we use complementary approaches aiming to improve gait capacity in affected people. This involves spasmolysis, training, both task-specific training, but also interventions aiming to improve overall physical activity. Sometimes the use of orthoses or shoes, and there's also surgery. And in my today's talk, I will highlight each of those treatment modalities. So let's start with spasmolysis. So roughly speaking, there are two types of spasmolysis. Oral treatment, for example, using baclofen. We use this in people with HSP, but mainly with the aim to reduce disabling pain in the legs and not to improve gait capacity. Instead, focal spasmolysis, for example, using intramuscular botulinum toxin injections, can be helpful to target specific problematic muscle groups around the ankle, hips, and knees, as was also stated in this excellent review on HSP, which was published last year. Ideally, all treatment modalities are preceded by an instrumented gait analysis. And this is certainly the case when treating overactive muscles using focal spasmolysis. So during instrumented gait analysis, you can see which muscles tend to be overactive during which phase of the gait cycle. And instrumented gait analysis can also be used to evaluate a treatment, but also to monitor treatment effects over time. So I'm curious which of the audience applies instrumented gait analysis before starting with focal spasmolysis. Can you introduce the question, Sanja?
Yes. Just let me give me a second. Yes, here.
Okay. Can I see the results?
We would let another 15 seconds so that everybody can vote. Around 70% have voted until now.
Okay, excellent.
Okay, I will now end the poll and show the results.
Okay, so it's about 50-50. So half of the people applies instrumented gait analysis before starting with focal spasmolysis, and half of the participants doesn't do that. I can imagine that you do not apply it when instrumented gait analysis is not available. Perhaps there are also other reasons, and if participants want to share them, you can type them in the chat. In our center, we use focal spasmolysis mainly for the plantar flexors, so gastrocnemius muscle, soleus muscle, tibialis posterior muscle, but also for the hip adductors. And our group has performed 2 studies in recent years aiming to increase the scientific level of evidence of focal spasmolysis in HSP. And these studies were termed the Feebach studies. Feebach 1 focused on toe walking due to overactive calf muscles, and 15 patients participated in the study. And Feebach 2 focused on gait scissoring, or a narrow base of support, due to overactivity of the hip adductors. In both studies, we used botulinum toxin type A, but in the Feebach 1 study, we used Dysport, and Feebach 2 study, we used Xeomin. The target muscles in the first study were the soleus and gastrocnemius, and in the second study, it was the adductor longus, adductor magnus, and gratulus muscle. And focal spasmolysis was accompanied by self-administered daily stretching exercises. So this was the design of the study. There was a baseline measurement, and then there was the intervention with botulinum toxin type A. Then there was an evaluation at T1, 4 to 6 weeks after the intervention, and then another measurement after approximately 4 months. In the study that focused on the toe walking, our primary outcome was comfortable gait speed, but we also looked at measures of spasticity using the modified Ashwood scale, muscle strength using the MRC strength scale, and we also evaluated gait speed, whereas in Feebach 2, the primary outcome was gait width, and again, secondary outcomes focused at spasticity, muscle strength, and gait speed. Well, when looking at the results for the first study, so that focused on treatment of the gastrocnemius and soleus muscle, there was a significant increase in gait speed after 4 to 6 weeks after the intervention. There was a slight reduction, but significant reduction in the modified Ashwood scale, but also a slight reduction in muscle strength. So at baseline, muscle strength of the calf muscle was MSC score 5, so the maximum score, that was the median score. And after 4 to 6 weeks, the median score was reduced slightly to 4. The maximal gait speed did not change. And when looking at the study that focused on the hip adductors, was a significant increase in gait width. And again, we saw the same pattern for the modified Ashwood scale and muscle strength. So there was a significant reduction in the spasticity as measured with the modified Ashwood scale, but also a slight reduction in muscle strength, again, from a median score of 5 to a median score of 4. We also observed a significant increase in comfortable gait speed, but again, not a significant increase in maximal gait speed. After 4 months, we saw the same pattern. However, the muscle strength was returned to baseline values. So the interim conclusion from these Feebach studies was that botulinum toxin type A in critical muscles results in a reduction of muscle tone, a slight temporary loss of muscle force, an 8 to 12% increase in comfortable gait speed, which was found in both studies, targeting the calf muscles and the hip adductors. And there was a significant increase in gait width when targeting the hip adductors. Well, to further increase the level of scientific evidence, randomized controlled trials are needed, which is obviously a challenge in a rare disorder, but hopefully we will be able to do this in the future using multi-center studies. So I will now highlight training very briefly. There are 2 types of training. Ideally, training by a physiotherapist should be, in my opinion, task specific. At our center, we use often CMIL to aim to improve gait adaptability in people with HSP. And the CMIL is introduced in this video. The CMIL is a treadmill on which projections are projected by a beamer, and then the participant is instructed to step on the obstacles or to step over obstacles. And by doing so, patients are challenged to adapt their walking pattern, which is often affected in people with HSP. So as stated, we have very good clinical experience, practice-based experience with CMIL training, but we are now also conducting an RCT to see whether we can also increase the scientific level of evidence for CMIL training in HSP. It has already been shown that CMIL training is effective in people with degenerative ataxia, but we will now try to show that it's also effective in people with HSP. And we do this in an open label RCT, which aims to include 36 people with pure HSP, which are randomized either into a control group or to the intervention using CMIL. And the control groups involves usual care. And the primary outcome is the obstacle subtask of the MRE functional ambulation profile. And I hope to present you the results of this study in the coming years. Well, so training by physiotherapists ideally should be task specific. I think we as clinicians, we all should also motivate people with HSP to improve levels of physical activity. And I'm curious whether the audience thinks whether a reduced physical activity will impact on gait impairments or not. So perhaps we can introduce the poll, Sanja. Thank you.
Fifteen seconds left. You can still vote. Okay, so I will show now the results.
So 65% thinks that reduced physical activity will increase experienced gait impairments.
I have put it twice.
No, it's
It's not?
different. So, and
No,
the
will
second physical thing that reduced physical activity will also
reduce.
reduce the experienced gait impairments. So this is interesting. Well, we used the latest COVID-19 lockdown to investigate this question, as we expected that people with HSP, like the other population, would experience reduced levels of physical activity during the COVID-19 lockdown in the Netherlands. And we also expected that this might negatively affect spasticity-related symptoms such as gait impairments. So we used a web-based survey during the lockdown, and we invited 109 people with pure HSP in the Netherlands, and 58 people responded. And of those 58 people, the majority indeed reported a reduction of physical activities, so 74%. And also the majority of people reported an increase in experienced symptoms. So for example, 68% experienced an increase in muscle stiffness, but also 60% experienced a subjective increase in gait problems. If you're interested in the other symptoms, would like to refer you to the paper by Lotte van de Venis, which was published last week in Journal of Neurology. But I will now focus on the gait problems, the experienced gait problems. And if you see the black bars, those are the people who experienced a subjective increase in gait problems. And as indicated by this figure, those who also reported a decrease in physical activity significantly more often experienced an increase in experienced gait problems. So this study suggests that maintaining levels of physical activity are important in people with HSP, as in recent years also been shown in other neurodegenerative diseases, such as Parkinson's disease. I think as clinicians, it's important that we also motivate people to maintain sufficient levels of physical activity. I will now briefly highlight the use of orthosis in gait rehabilitation. So this is the frontal view of a patient that I also used in the beginning of my talk. This is the sagittal view in slow motion. So I already stated earlier, this patient has difficulties to make a heel strike, and therefore she's more likely to trip and to fall. And also during the swing phase, she has a tendency towards a foot drag, predominantly on the right side. This is the same session, but now she walks with a dynamic ankle-foot orthosis. And when looking at the sagittal plane in slow motion, you can see that now she makes a heel strike, and that also clearings during the swing phase improves. So the use of orthosis, and in the case of ankle-foot deformities, shoes, is important to compensate for muscle weakness in people with HSP. Then I'm already arrived at my last category, surgical interventions. To my knowledge, surgical interventions have not been scientifically evaluated in people with HSP, but in our center we have good practice-based experiences with surgery in selected people with HSP. And before introducing one case, I'm curious whether which one of the audience considers surgical interventions as a treatment modality in people with HSP.
Okay, already 70% responded, but we can let another 10 seconds to the others to respond as well. And then
if you do not consider surgical interventions, I also invite you to write down in the chat why you do not consider surgical interventions. And Sanja, I cannot see the chat, I think, so perhaps you can then, if you have relevant answers, you are free to interrupt.
Okay, okay. For the moment, there is no input on that subject, but if there is, I will tell you.
Okay, thank you.
Yeah. So, and here are the results.
Yeah, so it's again 50-50. So a slight majority considers surgical interventions, 57%, whereas 43 participants does not consider surgical interventions. So if you want to elaborate on this, you are free to write a comment in the chat. I will now introduce our case. Let me see.
Yes. Just right now, somebody wrote, depends of the spasticity in muscle length and muscle length.
Yes. Yes, so I fully agree with that. So you should take several factors into account. Obviously, the degree, whether there are contractures, also whether there are spasticity, but also whether there's muscle weakness. There are two types of surgery which are often combined. So there's soft tissue surgery. One example of soft tissue surgery is an Achilles tendon lengthening, which can be used in people with both a shortening of the gastrocnemius muscle and the soleus muscle. And there is also bony surgery, for example, triple arthrodesis, which we apply in people with a rigid varus deformity of the hindfoot. I will now introduce a case in which we applied Achilles tendon lengthening. So this was lady, I also show footages of this lady in the beginning of my webinar. Well, there's clearly toe walking, and in this patient, toe walking was due to a contracture of both the gastrocnemius and soleus muscle. And there was a relatively good strength of the calf muscles, despite the shortening. This is the same lady, but now after bilateral Achilles tendon lengthening, you can see that the gait pattern significantly improved. There are quite some clinicians who are hesitant with Achilles tendon lengthening because they are afraid that lengthening the Achilles tendon may induce further weakness of the calf muscles and therefore instability during the stance phase during gait. Well, I agree this has been described and has been seen in people with cerebral palsy, especially when they have surgery on childhood and then calf muscle weakness becomes present when they grow older. In people with HSP, it's important to check whether the calf muscle strength is relatively good, as was seen in this patient, whether there's a relatively good selectivity of movements. And then we have good experiences. We did an instrumented gait analysis. Here I show you the figures of the ankle powers. The blue lines represent the curves before surgery. The red lines, the curves of the ankle powers after surgery. And so if you would induce muscle weakness by the surgery, you would expect the ankle powers to deteriorate. But in this patient, we saw the reverse pattern. So there was actually a clear improvement in ankle powers, and likely because she now has a more range of motion to use the available muscle strength. Hopefully we can evaluate these types of surgery, but also the bony surgery at group level in people with HSP in the coming years.
Jorik, there are two inputs or feedbacks from two attendees.
Yes.
Kate says, risk of effects of taking someone off their feet post-surgery, will benefits definitely outweigh risks? And another one, another participant, Alban, says, unless the condition of the muscle spasticity is severe, I wouldn't consider. I would consider how much it will improve the quality of life of the patient.
Okay, so regarding the first comment, yes, well, I agree, you should always take it into account. The surgery is a huge investment for a patient and the caregivers. as after surgery they have to be in serial casting for a period of time. Well, my experience is that most patients recover well. We try to improve cardiopulmonary condition, but also muscle strength in the arms before surgery, such that people are ready and for surgery and they are able to walk with crutches afterwards. But obviously in a patient with a very poor walking condition, you should consider whether the benefits outweigh the investment and possible disadvantages. And regarding the second question, so we also do surgery in people with contractures, so that's a main indication for surgery, also when there's not a very pronounced spasticity, also with good effects. So my key points are that gait impairments are a key feature of HSP. Ideally, an instrumented gait analysis is performed before starting treatment. Treatment should be personalized and may involve complementary non-pharmacological, pharmacological, and surgical interventions. I would like to thank our team at the Radboud UMC, involving neurologists, physiatrists, physiotherapists, and occupational therapists, and researchers. And the floor is now open for questions.
Right. Thank you, Jorik. And now we go to our questions and answers session. In what body position did you test spasticity? Did you use test motor control verticalization for strength analysis?
Yes, so what we typically do is that we test spasticity just on the bench when patients are lying down. And we test muscle strength both on the bench, but also and primarily during functional exercises. So asking patients to stand on their toes on one leg, to walk on their heels, that types of exercises. And then the second question.
What do you think about the selective dorsal rhizotomy to reduce spasticity? Many specialists are starting to propose it to patients with HSP, creating a lot of uncertainties and doubts.
Yeah, excellent question. Here in the Netherlands, we do not perform selective dorsal rhizotomy in adult patients with HSP, also not in children. It's used in the Netherlands for children with CP. When there is a more generalized spasticity in the leg muscles, and which is such severe that you cannot get good treatment effects using focused spasmolysis or oral medications such as baclofen, then we use intrathecal baclofen, often with good effects. So that's preferred above the selective dorsal rhizotomy.
Okay, thank you. And how is the balance assessment findings of these patients?
Yeah, so in daily clinical practice, we also always ask our physiotherapists to perform the mini-best score. And in patients who are more severely affected, we do the work balance score. And balance is often affected in people with HSP due to spasticity, due to muscle strength, due to impaired proprioception, but also due to contractures. So it's indeed very important to monitor this when you see a person with HSP.
Right, thank you. Okay, so at the moment, here there is one that we have received in the chat box. Do you strengthen the calf muscles? Again, I will open that box. Do you strengthen the calf muscles or dorsiflexors before surgery?
Yeah, so you would only do that when you expect that there's disuse. And otherwise, in my experience, it makes no sense to give patients a full training program, as you cannot further improve muscle strength. So if you expect disuse, for example, in patients with reduced physical activity, then indeed I would recommend to try to improve muscle strength of the dorsiflexus and plantar flexus. If patients have normal levels of physical activity, then, well, I always advise patients to try to be as fit as possible before surgery, but I do not specifically focus on those muscles.
Mm-hmm. Okay, thank you. So if we don't have any more questions, we can go further to the next part of our webinar today. And anyhow, Jorik will be here still if you still have one last question. Well, let us take this one last question. How long after surgery will patients be advised to not bear weight on their feet? When are they allowed to walk again?
Yeah, so it depends on the type of surgery. If you only do soft tissue surgery, then patients get serial casting often for, it depends a bit on the patient, but often for a period of 4 weeks. And then they can gently apply weight on the serial cast. If you apply bone surgery, for example, triple arthrodesis, then the period is longer. So then there's 4 weeks when patients are not allowed to stand on the leg. And then this is followed by 4 weeks in which they have serial casting and they are able to make a few steps with the serial cast. And then after those 8 weeks, so it's 4 weeks during which patients are not allowed to stand on the leg, then 4 weeks in which they are allowed to make small steps. And then they get what we call a moon booth or walker. And then using that walker, you gradually are going to train weight bearing and walking. So in total, it's a long trajectory, and it takes 3 months before you can fully walk without serial casting or a walker.
Mm-hmm. Okay. Okay, thank you. So we have answered the questions we have received, and do not hesitate to ask more questions. Jorik will be there still, but we will go further now with the second part of our webinar, which will be presented by Martin Serp from the Charles University and General Hospital in Prague. So I will share my screen just. Yep, okay. So Martin is a physiotherapist and PhD student at the Department of Neurology and the Center of Clinical Neuroscience at the General University Hospital in Prague in Czech Republic. And he focuses on respiratory physiotherapy in neurological patients and physiotherapy in spastic paralysis. His current project is safety of long-term injections of botulinum toxin. So Martin, thank you very much for accepting our invitation, being together today and sharing your knowledge, and the floor is yours.
Hello everybody, thank you for the opportunity to be here, and let me share a screen with you. Okay, so my field of focus is respiratory physiotherapy in Parkinson's disease and in Parkinson plus syndromes. My biggest expertise is in multiple system atrophy patients. Therefore, I will be talking about them during today's speech. And let me start with a question. I wonder if you have an opportunity to measure the cough effectiveness in your patient at your workplace.
Yes, I will just now blend in the question so that people can vote. Martin, in the meantime, can I ask you to change to the presentation modules in PowerPoint so that we see the full screen?
I already did.
Oh, I don't know why I have that view. Maybe for the others is okay. In that case, since we didn't get any other input, it may be okay for the others. For the other attendees. Okay, so 10 seconds more because there are around 75% that have responded already. Okay, so here I will show you the results.
How about now? Is it better? Can you see full screen?
Me, I cannot, but I hope the attendees can see the full screen of your presentation. Now it is better. Yeah.
Wait a sec. Now I can't see the screen. So the answers, 25% have an opportunity to measure the cough effectiveness. It's great. In our country, usually nobody get that opportunity, and 63% says no. Why I'm asking about this question? I'm respiratory physiotherapist, and if physician ask me to prescribe the respiratory physiotherapy, I need to know what is his cough effectiveness, concretely measuring by peak of flow. If we measure value above 270 liters per minute, it means that the patient's cough is effective, and therefore there is no need for specific respiratory physiotherapy. On the other hand, if we measure the peak of flow, the cough effectiveness is below 270 liters per minute, then we know that patient got a problem with cough, and he's definitely indicate for specific respiratory physiotherapy. It depends what is the value, and if the patient score between 270 liters to 160, the cough is weak, but it's not that weak, and we can start work to straighten the cough. For example, using expiratory muscle strength trainer, which got pretty good evidence to straighten expiratory muscles, which you need to use when you are coughing. If the patient score below 160, we're still using the expiratory muscle strength device, but we have to use something extra, what will immediately help with the lung hygiene, because the cough is very, very weak and patient is in a risk with pneumonia. So we use this type of device, which is called mechanical insufflation exsufflation device, which with overflow brings air into the patient's lungs, and then it vacuums that air with mucus and foreign particles out. This is management of the respiratory therapy at our clinic for our neurological patients. And now let's go to multiple system atrophy patient to see if they need respiratory physiotherapy also. We know from evidence that patient with MSA, if you compare with a control group, their respiratory muscles are weaker. MSA patients are in green and control in blue, and we see the significant difference between those two groups. So we know that those patients could be affected with cough weakness. And with another knowledge, which is that leading cause of death is pneumonia, then there is a really good reason to use respiratory physiotherapy. So let's go and see what is the evidence about respiratory physiotherapy in MSA patients. In local guidelines for MSA patients, there is nothing stated about respiratory physiotherapy. So far, the best evidence what we can use is the European Physiotherapy Guideline for Parkinson's disease, which also contains part about atypical Parkinsonism, and there is stated that if the person also has sufficient mental function to comply with treatment, we can use recommendation of this guideline. And those guidelines refer that respiratory muscle strength training could be effective. This evidence mostly comes from patients with Parkinson's disease. Respiratory muscle strength training was proven to be efficient for improving muscle strength. Also, it increases pico flow. In another word, it increases cough strength for better lung hygiene. So this small device which you use for expiratory muscle strength training could be effective for dystocia problems. Dystocia is problem with cough. Another studies also found that this type of training could be also effective for swallowing problems. Patients who suffer for dysphagia after the trainings get better. Its penetration and aspiration get better. It's lowering it. So this type of training could be effective also for dysphagia. And lastly, if we incorporate this type of training into the patient's program, there is evidence about reducing also speech problems, concretely respiration during speech, vocal loudness, and sustained phonation. So if we do conclusion, this expiratory muscle strength training could address three, in my eyes, main problem in later stages in Parkinson's disease, but also in MSA patients. What is evidence in MSA with expiratory muscle strength training? Well, so far there is none. And therefore, we carry out this pilot study where we recruited 9 MSA patients and they perform expiratory muscle strength training for 8 weeks, 5 days a week, and during the training day, they perform 25 expiratory maneuvers. This is a demographic for our cohort. The age was, the mean age was 62. Disease duration was 5 years, and most of the patients were cognitively intact. And what was the primary goal is find out if this training is feasible. And we found out that it is feasible. Most of the patients were able to follow up our protocol. And we also find out that after the training, 2 months of training, they significantly got better in expiratory muscle strength. With this knowledge, it would be really interesting to carry out larger study, randomized control, where the primary target would be one of those 3. What this type of training, if this type of training could really address pico flow, dysphagia, and speech problems. And this could be a really great opportunity for a multi-center study. What we also find out, there are some barriers for this type of training. The first one is that the therapy is not that much rewarding. There is no feedback. Patients, in some case, they perform with poor exercise performance. This is the first barrier, and the second one is because our center, our expanded center, is the only one in Bohemia. So the MSA patients travel a long distance to come to visit us. And for a lot of patients, we asked to cooperate us. It was a big problem because during the expiratory muscle strength training, you have to have a visit a patient every 2 weeks to set a proper load. We need to increase the load. Same when you are weightlifting, you need to increase load during the training to reduce the plateau phase and to get as much strength as you can get from the training. So now we are working on this video feedback application for mobile phones, which would address those two barriers we found out. The first one I was talking about is the poor training performance. And we were thinking that if we add something what is entertaining and what will also show you how you perform, this could help and motivate the patients. As you see me training with the expiratory muscle device, you see the black bar which represents the voice, the white notes from the AMST expiratory muscle training device. It shows you the strength of the exhale through the device, and also it shows you for how long you can keep that proper exhale. The application also show you a lot of statistics, which also should patient motivate. We also carry out the pilot study about this application, and we found out that it's feasible and it really motivates patients. So, but it was just a pilot study. What also this application can do is that the statistic from the training sends to their physiotherapists. As you can see here on this screen, I can see every single one expiratory maneuver, and this gives me opportunity to see the strength of the expiration, and also for how long they could keep the expiration in the training zone, represented by red horizontal lines. And with knowing the mean strength and mean time in training zone, I'm able to do the progression in the training zone via the internet. If the patient performs that he can, his mean strength and mean time in training zone is constantly good, I'll call the patient and tell him, okay, you are fine now. We should increase the load. So this could address the second barrier, which is the problem with coming the patient for the visit every 2 weeks. And now let's summarize my presentation. I want to say this often overlooked problem, respiratory physiotherapy in most neurological patients is often overlooked. The topic in MSA patients is really unexplored, but what we know that it could be feasible, and therefore there is a clear need for bigger studies, which would prove that we would show that if this training is possible, if this is training is effective. And let me finish my presentation with a second question, and that is if you want to cooperate with us. And if you say yes or no, on my last slide, there is an email address where you can rewrite, and we can talk about this and maybe settle a study together. Thank you.
Thank you, Martin. I will blend in now your last question. Maybe you would like to give some details of intended collaboration. In what sense do you would you like to collaborate with other centers to have more patients of this in the same group, or yeah?
Well, to prove it, it would be great to carry out randomized control study. Therefore, we need to have 2 arms with many patients, and because the MSA is a rare disease, it would be easier if there would be more centers. That is clear. This is clear reason why it would be great to have more centers cooperating together. And we also got expertise in this, so we could help. with setting the protocol and everything.
Okay, great. So I can now show the results.
Wow, so 44% want to cooperate with us, and I mean today there is a 70 people. That's a lot of centers. Great. So if you want to write me an email, we sure definitely can think about
Great.
cooperation.
Yeah, this is a nice initiative, and first such question in our webinars. But why not? This is very nice idea to ask people and to start a collaboration from a webinar. Great. Okay, so do you have any other questions for Martin? We are expecting questions in the Q&A box. If so, just please write them, or also you can use the chat box, or some questions for Jorik too. Yeah, we can wait another minute to see if there are some questions coming in. If not, we can close the webinar. Okay, there is one. Endurance training is not enough.
Endurance training should be,
Well,
maybe specific.
yeah, maybe.
General endurance training. We carry out this study about circle training, where you have straightening exercise, endurance exercise, and those patients were training for 3 months, and we measure the respiratory muscle strength before and after, and we found out that there is no difference after the training, because this type of training is not that specific. If you want to specifically train strength, respiratory muscle strength, you have to have specific respiratory muscle strength training. There are also some other papers talking about it in multiple sclerosis, Parkinson's disease. The general endurance training don't significantly strengthen respiratory muscles.
Mm-hmm. Right, thank you. There was another one. Would this respiratory training help for HD patients too? Huntington patients.
Yes, there is, I think this year or last year was published an interesting article. It helps with respiratory muscle strength, and it's with cough. It's same with ALS patient. It does not increase the peak of flow, but it helps to it helps with the current. If we compare the control and expiratory muscle strength group, the one with active respiratory muscle training is still same, but the one without the respiratory muscle strength is the peak of flow decrease. So it helps to reverse it.
Okay. So another question, I'm interested in the app you talked about. Can I get more information, please? Martin?
Yes, I'm reading the question. Is it used to smartphone connected spirometer or evaluate the flows? We
no, we were at the one before.
Okay, I'm interested.
From Brigitte Wolf. Yes. I'm interested.
This application, we are now, let's say, on 800% done. Now we are working on a graphic. Once it will be ready, we want to put it on Google Play. Now it's just for the Android phones. And patient would get it for free. but they need to get the expiratory muscle strength device. This is only one thing what they need to get, but it's really easy to get from the Amazon, for example. And the application got its tutorial, everything. So once it will be released, everybody can get that application. So the question I was reading last time, is it possible to train the patient using the smartphone connected spirometer? The flow. We now only evaluate the flows, but it's indirect. It's we now evaluates the white noise. The first thing what we wanted from the application and the special hardware going together with the application, it has to be cheap. Therefore it's normal microphone, and the microphone evaluates only the white noise, and therefore the application and all the hardware you need to have is therefore cheap, but we can measure the flows, spirometer flows.
Okay, thank you. And yes, this webinar will be available after today on our website. This has been asked also. So I go to another question asked in the chat box. Can this training be used for patients with COPD or pulmonary fibrosis?
This is a little bit out of my topic. I don't work with the COPD patients and fibrosis patients, but yes, I know there is a bunch of evidence about it, but really it's out of my field, so therefore I would leave a comment.
Right, okay. Thank you. So it seems that there are no further questions. Thank you very much to you, Martin and Jorik, for sharing your knowledge today with us. And thank you to everybody that attended this webinar. And see you again in September. On the 8th of September, we are going further with our webinars.
Thank you.
Thank you. Bye-bye.